Our daily census at midnight, or our midnight census, was 349. When it relates to Bryan Easy Visit, we have now had 11,543 people complete the screening, resulting in 3,731 easy visits, and 1,754 individuals have used the COVID promo code. Testing results, the update on that. We have now tested 3,450 at either our drive-through Bryan Medical Center urgent care or our mobile clinic. It is now up to 296 positive COVID-19 results, 2,710 negative, and 444 pending. The breakdown by age, and you've heard John, myself, physicians, nurses, everyone talk about the importance of hand hygiene, social distancing, limit your gatherings of large people as we begin to think about opening up as a state. I think that can't be stressed enough, and we implore you all to continue to practice that, because when you see these age breakdowns, I think it's going to be a little bit surprising. Out of our positives so far, 7% of them are from individuals that are under 18 years of age. 37% of them are individuals that are between the ages of 19 and 44. 29% of them are between the ages of 45 and 54. 19% are between the ages of 55 and 64. 6% are between the ages of 65 and 74. Only 2% are between the ages of 75 and 84, and you have to really get into the decimal points because it's only one patient, or 0.4%, have been over 85. There's so much discourse out there about this really impacting the elderly, and it certainly does from the severity of it, but I think it's a misconception to think it's only attacking the elderly, and from the test results at Bryan, it's certainly proving it does not discriminate by age, gender, race, anything. So please continue to be careful. With that, I'd like to introduce John.
Good morning. My update will be pretty brief. We have 15 positive COVID patients in-house. 4 of those are on ventilators. We have 6 of those individuals in our intensive care unit, 3 in our progressive care unit, and 6 in our general care unit. As Bob talked about our mobile screening, we will not be screening today, and we don't believe Friday, but we will give you an update of where we will be next week. We're still working on the details of that. And we do have 444 pending results, but just to give you an example, we did about 288 tests just yesterday alone, so that's why you see the pending number rising a little bit. With that, I'm going to turn it over to our other guest.
Good morning. I'm Leah Harrington. As mentioned, I am the Assistant Nurse Manager of the Medical Surgical Intensive Care Unit here at Bryan East. I've been with the organization for 18 years now, and as best as I can describe our emotions at the front line is it's a complete roller coaster. No matter if we've been working with these COVID-19 patients or working with, the patients that we have historically, these patients either are critically ill and they get better or they don't. So as staff, we do our best at taking care of them. Some of the times that I can think of that have been extremely difficult have been, when patients are actively dying. It's the nurses that are the ones that are there holding their hands as they pass away. Picking the patients up from their private vehicle. Recently I had to tell kids in the back seat, we're going to take really good care of your mom. But then there's also those positive times, when the patients are extremely ill and we are having to prone them, meaning put them on their bellies so they can breathe on the ventilator, or when we're giving them the convalescent plasma and those patients that are improving. And when they come off of the ventilator, it's extremely rewarding. I've taken pictures of the patients on their own phone and sent it to their wife, so they can actually see what the patient is doing. The first diet Sprite that the patient got to enjoy, and those first times out of bed or the first steps that they take, because they are so weak and so ill when they do come off of the ventilator. Still, discharging patients is super rewarding. Pushing them out to the wheelchair or in a wheelchair to their car, seeing their loved ones see them for the first time in person, just extremely rewarding. So, that's what it is. That's what we do. We are blessed enough here that, as a healthcare provider, we do feel safe in working. We have been provided with the appropriate PPE, the PAPR hoods and the masks and the gowns and everything. So, just super appreciative of everything that we have here at Bryan.
Hi, my name's Dr. Bill Johnson. I'm a intensivist. I'm a pulmonary and critical care doctor here at Bryan. I happen to be the director of the ICU. I'm asked to talk about a couple of things. I think from the start of this, Nebraska was lucky enough that we were able to have some planning. Collaboration has always been a huge part of our care. When you're taking care of somebody in the intensive care unit, it does involve a lot of people. It isn't just about one person. The collaboration of our nursing staff, respiratory therapists, pharmacists. We have leaders there that all have tremendous input that we work very hard to make sure that the outcome when somebody gets ill is the best that it can be. Taking care of somebody who's critically ill is oftentimes about supportive care, and even though this disease may not have specific treatments that we're aware of, we have adjusted to those treatments, maybe starting off with hydroxychloroquine and then moving into convalescent plasma, and potentially now we're hearing about remdesivir. Those are all things that we've looked at and worked hard to make sure our patients have available. Sometimes it's simply giving the patient the chance to recover from an illness that they may not otherwise recover from and giving them the supportive care that they need. And that requires all that teamwork that we talked about, and we've always been real blessed to have such a multidisciplinary approach. And it starts really at the very beginning. The emergency room doctors and nursing staff and respiratory therapists that work in the ER have been tremendous. Anesthesia has helped us in areas of intubations and IV access. We've had multiple meetings on about a daily basis in order to organize the care that we have. And so those are all things that are real important. I've heard a lot about being at the front line, and I think from a healthcare provider, this is what we've always been here, we'll always be there. I think taking care of a disease we don't know about has caused some fear, but we're not like the military or the policemen or firemen or those people that are out there that are always doing that, and so they're the real heroes. But we do what we do, and we've been blessed that Nebraska has flattened the curve so that we can do what we do, which is help our patients get through something that they may not otherwise have been able to do. I do think the spirit of the workforce is excellent. It's an illness that has gained a lot of obvious attention, and so being in the middle of it has been interesting and something that's obviously worth it for us. I have two daughters that are doctors, and we've talked about it, and one comment I gave them was an experience I had when I told a 60-year-old gentleman that he was going to go home the next day, and I thought he was going to cry. And I realized then that we talk about people at home not wanting to get the disease. We talk about healthcare providers not wanting to get the disease, but I don't know that we talk a lot about the people who have the disease and how scary it is for them. They think that they may die, and to get past it and get through it because we've helped them do that, it is really rewarding. And yes, that is what we all sign up for. And so we're happy to be here. We wish that this illness would go away, and I think that we'll get to a place where things will open up in a safe way and we'll get back to the world that we want it to be. So anyway, thanks. Medicine's a science, and we don't like to guess work at things because our patients' lives depend on it. And obviously with this illness, it's been a moving target. There are two antibodies, IgM and IgG. The IgM tends to infer recent infection, and IgE tends to infer a later infection. I don't know that we can measure those and say that a person's immune, but there are things that are involved there, for instance, that could potentially help us if a person would be a candidate to be a donor for convalescent plasma, for instance. And so that is a place where it could come in. Maybe we'll know more as the weeks and months go by.
Well, basically, the average temperature, if it's oral, is 98.6, and we are using forehead reading thermometers, and they can be anywhere from 2 to 3 degrees lower than that 98.6. So what has been kind of put in place as people were coming in with low temperatures and questioning the accuracy of it, if someone arrives and has a temperature that is lower than 94.5 right now, they're asked to stand to the side, and then they go through 3 more tests to let them warm up. But something that can really impact the surface temperatures is if you come inside and it's been cold outside, you're going to register a little bit lower. Or if you have your air conditioner blasting on your head as you're driving in. So those extra measures are put in if it's abnormally or below that 2 to 3 degrees lower than it should be, or at 94.5, we will retest you to see what the temperature is when it comes up. But again, normal temperature is 98.6. The forehead readers are usually 2 to 3 degrees lower, so the team there, they understand all of that and will allow people in or retake the temperature as needed.
Yes, it does get easier as time goes on. I think initially all of the fear of the unknown, as we are actually experiencing it, it does get less stressful. How we stay healthy, we have one another, and as our coworkers, we just vent to them or share our happiness and our sad times with one another. So of course our families too. So.
Staying healthy is important for us, and we have to keep healthcare providers healthy, and that's part of the safety measures that we've taken. We've worked together for a long time taking care of sick people, and there is a lot of sadness that goes with it, but there's a lot of good things that come out of it as well, and happiness that comes out of it, and to see somebody recover is what makes a lot of it worth it. This has been available for compassionate use, children, pregnant people, but I think I saw yesterday that the FDA might approve it more rapidly. I think the concern that we're going to have is going to be availability. Obviously, how do you make our healthcare system isn't set up for one disease that affects so many people all at once. It's just not made that way, and so getting those drugs to us, if they're available, are important. Having good scientific basis for the drugs we give patients is just absolutely critical, and it's something that we really need to have, and only time will give us that. So, yeah, everyone's excited about it. We'll see. When anyone is sick, the goal is to give that person the best chance of recovery that person can possibly have, and that takes a lot of organization. It takes a lot of teamwork. It takes everybody working together and being on the same page. We've had people that have come in that have been as sick as I've ever seen. It's been a fascinating process to see it happen. I've worried a little bit about people staying home too long and getting real sick at home because of the stay-at-home type of concept. And that's worried me some. But I do think that that the organized care that we give has helped. I agree with the fact that there are some people that are going to die of this disease no matter what you do. And if we can give everybody the best chance possible, we're going to come out on top. And as long as we're able to give people care and not get overwhelmed, then that's a win when it comes to this disease.
We're keeping this out of the nursing homes and the assisted livings and where people are the most vulnerable. And I think I've got to comment again about the social distancing and people thinking about how are they interacting with their loved ones or their grandmothers or whatever. You know, we want you to stay in contact with them, but there's ways of doing it without being next to each other. And long as people continue to do that, we're going to lower that likelihood that the most compromised individuals are going to be exposed to this virus. So just keep doing what you're doing, and I think we'll be able to continue to flatten the curve.
There was discussion on Tuesday about Wednesday doing treatment on a patient with convalescent plasma again.
At the beginning, hydroxychloroquine seemed to be one that may have promise. We've used it in patients. I think we're less excited about hydroxychloroquine, maybe more excited about the remdesivir in terms of a medication. The convalescent plasma is something that we have used, and in patients that come in who are ill, we have used that. I've used it several times, and so as they come in, that's it. Plasma does have the test of time. Giving a patient plasma is not something that is new, and so that is something that we've done and will continue to do for now when patients come in. If remdesivir becomes available, I think we would probably lean towards that one more than hydroxychloroquine now. But again, we have to wait for the studies to show what works, and that's what we'll use. And we tend to follow things real closely, and new information comes up hourly in this disease. Thus far, we've not had an opportunity to use that because, as I've said, it's been limited to compassionate use only. And we have not had anybody here that has qualified for that use that I'm aware of. But again, as times change and the FDA rules change and the company makes the drug more available, yes, we may turn to that. I think the patients that have not survived have been people that you would probably not expect to survive any critical illness. But the people that we have prone, this is a disease, to best explain it, the way blood flow goes in your lungs and the way the disease affects the posterior portion of your lungs. When you turn a patient on their stomach, you're getting better ventilation and perfusion matching is what we call it. And so it does work. And it's intended to be a way to get a patient through time so that patient can actually recover on their own. So much of caring for somebody in the intensive care unit with this type of disease is letting their own body recover and giving them the time to do that when they may not otherwise survive on their own. And so, yeah, prone positioning has been something that has gained a lot of interest in this disease simply because of the way the disease affects the lungs.